Hey everybody, it's Len Zwelling again with Andrew and our guest, Dr. Tim Connolly, who happens to be our doctor, and it's another episode of A New Prescription. We're going to talk about obstructive sleep apnea, and boy, do you have the right panel because we've all got it. We are all CPAP men.
That's
So,
right. All
Tim,
three of us. All
yeah,
three of
that's
us.
right. So, Tim, most important, I think, to start with, what is obstructive sleep apnea? I don't think people really know.
Yeah. So everybody assumes that sleep apnea is the same thing as snoring or the same thing as feeling exhausted. But people can absolutely have both of those things going on independent of any physiology. If you stay up all night watching TV, going out all night partying, you can certainly develop sleep deprivation. Similarly, people can have nasal congestion from allergies or other anatomic reasons that they might snore a little bit more than someone else. But snoring itself does not mean there's sleep apnea. Sleep apnea is where the airway, the upper airway, in terms of at or below the base of the tongue, so the muscles in the upper part of the neck, when those muscles relax excessively and the normal lumen or tube that is open and allowing us to breathe, when that tube gets constricted, collapses, closes off in any way, shape, or form, that's where there's disruption to the airflow, fragmentation of sleep, and that's where the clinical condition of sleep apnea kicks in.
And why is it when we sleep? Why doesn't it happen during the day when we're awake?
So when we're awake, our brains are sending signals to that muscle group in the neck so that you can breathe, run, fight, eat, talk, do whatever you need to do in terms of normal routine daily living. But the problem is, unfortunately, in contrary to God's great design otherwise, the upper airway was a very poor design, and it's such that there's easy choke points. And the problem is when there's a degree of laxity in those muscles, when the nerve signals are elsewhere, those muscles can collapse in on themselves, certainly exacerbated if patients have obesity, extra crowding, other anatomic reasons that may be genetic, why their jaw is recessed back a little further than their neighbor. So, certainly, when you're awake, even if you have severe sleep apnea like I do, I don't have any problem with airflow when my brain is sending signals to those muscles. But as my wife will tell you, when I start dozing off late at night watching the end of the Olympics, I'll start to make some noise. And if I was left off of my CPAP at night, it would be an all night ordeal.
So let's talk about that right away. I want to talk about how it's diagnosed because I think you've just hit the way it's usually diagnosed.
Yeah, yeah,
Is that how it's usually history?
yeah.
Somebody says somebody else is snoring or something. Is that the most common?
Yeah, so I think there's a few different common ways that people make it to a sleep clinic or that sleep apnea is raised as a question. Certainly, when people are basket cases, when they feel wiped out during the day, when they are sending their paycheck directly to Dunkin' Donuts so that they can make it through a morning, people that are very exhausted, often the question is, okay, maybe there's some sleep apnea at play. Certainly, when bed partners recognize active snoring, loud, funny noises, gasping awake, stopping breathing for a period, that can be a very alarming observation and usually will prompt them to say, you need to get this checked out. The other group that's probably as big as those first two are the cardiologists will send us patients. And that's because the cardiologists are increasingly cognizant of the fact that untreated sleep apnea over decades can lead to real cardiovascular implications: coronary artery disease, high blood pressure, atrial fibrillation, abnormal heart rhythm, stroke.
Yeah,
And
that's my
so,
story. I was
yeah,
diagnosed by a cardiologist when I had atrial flutter.
Correct. And a lot of patients who come to us from the cardiologist seem a little bit surprised. They're like, I saw the heart doctor, I've got this heart rhythm, and they sent me to you for some reason. My breathing's fine. And so I have to give them kind of the tutorial that there is certainly a connection between cardiovascular disease and sleep apnea.
So how common is sleep apnea, and does it have a distribution equally in between men and women?
So it's not necessarily equal between men and women until menopause, then women catch up. Generally speaking, in the US, it's felt that about 1 out of every 4 men have sleep apnea, and it can be up to 1 out of every 10 women. Now, when you take into account the obesity epidemic within the US, it clouds it, and some studies even suggest 1/3 of all adults in the US have some risk factor for sleep apnea. Suffice it to say, it is very common in men, increasingly common in women after menopause. And unfortunately, if you have a low risk for sleep apnea but gain a tremendous amount of weight, that may tilt you over into a higher risk grouping. And so it's extremely common.
What about ethnic groups? Are there differences among the ethnic groups?
There are. And so if you think about it, everybody assumes sleep apnea is an issue of waist size. I
Hmm.
always try to make the comment it's an issue of airway size, not waist size. And so our airways are determined by a number of features, certainly our genetics. And so if mom and dad happen to be snorers, there's a good chance that we have inherited that from them. There is also differences in jaw structure between various ethnic groups. And the classic group that actually has the highest incidence of sleep apnea per capita on the planet are Asians. And that has to do with a facial structure where the jaw is recessed back a little bit more. It's what we call retrognathia. Whereas there are other folks, other groups of patients like African Americans, where the jaw structure is often more pronounced and anterior, and that actually opens up the airway a little bit further.
So
So, yeah,
when I had
definitely.
diagnosis made, I had to go into a sleep lab. My son now has the diagnosis, and he didn't have to do that. Let's talk a little bit about how the diagnosis is made, which is sounds
Yeah,
mostly from history, and then the test what the tests do, what they mean,
yeah.
and what it means to the patient with regard to therapy.
So let's start off in terms of, the testing and the diagnosis. One other thing that I will tell you that's very interesting, and I actually had a situation last week in clinic where I had 3 different people come in for sleep evaluation that was prompted not by a bed partner, not by them being tired, not by a cardiologist, but it was prompted by their Garmin fitness watch, which suggested their sleep was less than perfect. And
Wow.
so all these new smartwatches, the Apple Watch, the Garmin devices, these are raising red flags when patients are having low oxygen during sleep, heart rate variability issues, anything that could be a marker of stress during a period that's supposed to be fairly stress free is another way that we're now actually identifying some patients that are at risk and need further evaluation. So the reality is whether it's a symptom constellation or whether it's a Fitbit or a Garmin watch that raises a concern, certainly the history is something that can lead us in the direction that testing is warranted. But in order to diagnose sleep apnea, we do need a formal sleep study. And so back in the day, the sleep studies were in lab studies that were terribly cumbersome, lots of wires. You felt like the Bionic Man. You had glue in your hair, probes up the nose. It was a very, very uh, intensive investigation.
Yes, I remember.
Those are still the gold standard. And when there's any debate, confusion, or equivocal information, that's what we will ultimately go to. But I will tell you, more often than not, the in lab studies are really being reserved for people that have maybe some unusual sleep behaviors that need some additional video monitoring. They might have seizure disorders, or they're very decompensated cardiac wise, where we're worried about cardiac arrhythmias, and they may need a more advanced intervention. But for the majority of people, we are now relying on home sleep studies. And there are some different interfaces. Some are more user-friendly than others. The one that I used was not as comfortable as the one Andrew did. I used one that was a band across the forehead, almost felt like a miner's light. And it was a little bit cumbersome to sleep with, and there was a probe in the nose, but it gave the information. The device that we use now is a watch, and it's a watch you wear on the wrist. There's a probe that goes on the finger to monitor oxygen, and a lead on the chest, mostly to assess for body positioning.
Is that covered by insurance?
Yeah. And so again, assuming the criteria are met as a patient has risk factors such as snoring, excessive sleepiness, cardiac rhythm issues, anything that would be considered a risk factor for sleep apnea, then we would do the home study covered by insurance. It usually gives us a good answer in over 75% of patients. And so based on that, we can then order equipment if indicated, or talk about position changes, lifestyle changes, if that's more the recipe.
So you do the test, you get the data. What determines whether you do therapy? And we'll talk about therapy in a second.
Yeah. So first off, we have to say whether somebody's got sleep apnea, and if so, how severe.
Right.
So it is considered normal for all of us as human beings to stop breathing less than 5 times per hour during our sleep. Another way of saying that is I can completely stop airflow, gas myself awake 4.9 times per hour, and that's considered normal. Our bodies are able to handle that degree of stress. Once you get above 5 or more, that's where we start having the official formal diagnosis of sleep apnea. So 5 to 14 events per hour is mild, 15 to 30 is severe, anything more than, or 15 to 30 is moderate, anything more than 30 is severe. The most I've ever seen, there was a patient 165 per hour.
Mm-hmm.
But most,
I was way up there when I
yeah,
had.
mine was 32 per hour, 60 on my back. And so, generally speaking, I know there's different flavors and some people are more aggressive than others. I would say if you don't have any pre-existing medical conditions and you were dragged into a sleep lab by your bed partner because of the noise, if you're 15 events per hour or more, I'm going to be very aggressive suggesting treatment.
And what is treatment?
CPAP is the first treatment that we talk about, and we can get into that in a second. What I would say, though, when we get into the mild range, that's where it's a little bit more nuanced. And I know that there are a lot of people that will immediately order equipment for folks. I generally try to reserve that for people that are pathologically sleepy or that have significant cardiovascular comorbidities or depression, anxiety, where we know that even with mild sleep apnea, we can have a significant impact by reversing any events.
So CPAP is the treatment of choice. Let's
Yeah.
discuss what is it
Yeah.
and how do you do it?
Yeah. So CPAP, continuous positive airway pressure, is absolutely the gold standard. It's a treatment that was discovered back in Australia in the late 70s, early 80s by a guy, Dr. Sullivan, in Epworth Hospital in Melbourne, Australia. He was a pulmonologist who recognized that some of the patients he had in the ICU who were having disrupted sleep, when they had episodes that warranted going on non-invasive ventilation, where you wear a mask and air is blown into the airway, that not only did it improve their clinical situation of pneumonia or heart failure, but their sleep was also better. And hence was born the field of sleep medicine. So, as pulmonologists, we deal with this idea of blowing air into one's lungs to try to help in respiratory failure situations. So the mechanism, the machines are something we deal with all the time. That's why on an outpatient basis, these little CPAP units, which are basically mini ventilators, that's why we have kind of taken over that realm of medical care. So the machine is basically an air pump. I tell people it's like a vacuum cleaner in reverse. So if the airway is trying to collapse in on itself and we blow a column of air in to hold those airways, those walls open, we can achieve basically the reestablishment of airflow without any drugs, medicine, or surgery.
There is something advertised on television now over and above this.
Yeah.
What is it and how does it work?
So Inspire is a new device that has come on out onto the market, and it is a hypoglossal nerve stimulator. In English, what that means is those muscles in the neck and at the base of the tongue that are losing their nerve signal and so therefore collapsing in at night. The thought process was if we can send an electrical signal, a voltage to those muscles when the natural voltage has gone away, would it be a way to keep them tight and open so patients wouldn't have to go on a CPAP at night? I tell people that it is a fascinating idea physiologically. I think it certainly is something that we will see in various iterations and generations to come. Will it actually find its niche? The problem is the technology hasn't fully caught up yet with the theory. The marketing is fantastic, and I know they're working actively trying to streamline the process and work on protocols to make it more user friendly. As of right now, it's something that when you look at the actual marketing and you talk to the reps of the company, it is really reserved for people with moderate, more likely severe sleep apnea who have failed CPAP. And so it really shouldn't be thought of as a first line therapy yet. They haven't fully worked the kinks out. It's almost
It is FDA approved though, I guess.
It
I assume.
absolutely is FDA approved, and the studies have shown that, generally speaking, in a controlled setting, they were able to reduce the number of events per hour by up to 67%. The reality is, I will tell you, our practical experience of that is it's not quite as robust. But again, when you're dealing with people that have severe sleep apnea and are running out of options and are intolerant of other treatments, that is certainly something that can be discussed with a sleep specialist as an option.
Well, one thing I've heard people tell me who have trouble with the CPAP machine is, oh, I'll just live with it. But the fact of the matter is there are complications to sleep apnea and they're fairly severe or can be.
Absolutely. I mean, it's something where I will say, back in the day, and I'm talking about 15 plus years ago, when we would put people on CPAP therapy, the masks that were being used were generally large, full face masks akin to what Darth Vader would wear or, Tom Cruise in Top Gun might put on. They were very cumbersome. Furthermore, the machines were really literally a black box. We would set it, send it home with patients, cross our fingers, and hope they felt better. So it was a very it was the blind leading the blind. And I will tell you, not surprisingly, the compliance rate with CPAP back then was probably on the order of 50%, 50. I would say with the new machines that are quieter, more user friendly, they speak to the smartphone, there's daily feedback, and the masks are significantly more comfortable. And we've really gravitated more to nasal masks for most people. The compliance rate is up in the 90s at this point.
What's the consequences of not treating it?
So, anytime you've got significant obstructive sleep apnea that is not being addressed, there is chronic fragmentation of the sleep quality at night, which leads to chronic sleep deprivation. That, in and of itself, can be problematic for relationships, functioning at work, keeping your cool in Houston traffic. whatever other dynamics are going on in life. But the biggest issue is the chronic onslaught that your heart feels during the repeated episodes of breathing against a closed airway and the afterload or the stress that's applied to the heart is long term very injurious. It's going to cause a lot of problem for cardiovascular beds throughout the body. It can impact the heart, it can impact the brain, it can impact erectile function, acid reflux, mood, memory. There's nothing that's immune. And so, no different than me saying, smoking cigarettes is really bad for the blood vessels. One cigarette doesn't kill you, one pack doesn't kill you, but years of smoking will absolutely have long-term ramifications.
The
And
connection,
that's the way it should be thought of for sleep apnea as well.
is there a connection with dementia? It's been spoken of.
So yeah, I mean, dementia is something that is certainly in many instances due to vascular blood flow issues. There are other types of dementia, Alzheimer's, Parkinson's, but when you're talking about vascular dementia, which is probably the most common that most people in the United States deal with, just like heart disease is the most common cause of death. When you're dealing with vascular beds, anything you can do to improve and enhance blood flow and reduce strain and stress on that vascular system is going to likely translate into a reduction in cognitive issues moving forward.
One of the things that Andrew brought up when he first, well, the way it went, I guess I should tell the story. We went on a golf trip.
Yeah.
And it was clear to me that he was snoring excessively. Now, his wife never complained, at least not to
Right.
me,
Right.
maybe to him, but it was pretty obvious to me that he probably had sleep apnea. And the question arose, raised the question actually is when it's detected in a young person, how soon can you treat it?
So again, I'm an adult physician, so I don't want to talk about pediatric sleep apnea. That is a little bit different. That usually is treated, believe it or not, with tonsillectomy, because most of the time in the pediatric population, sleep apnea manifests not as sleepiness, but hyperactivity, ADHD, poor performance in school. And when they see their pediatricians, they see that their tonsils are touching. And when those are removed, they improve on their growth curve, they improve in school. There's a lot of different elements. So, pediatrics is going to be a different grouping altogether, but we're going to talk about adults 18 or over.
Right.
So, if you are diagnosed with sleep apnea at age 18, absolutely positively, the benefit that you're going to get will be realized right off the bat. With that said, we all know, and as a parent of two young 20-year-olds, the last thing you want to do as you are dating and trying to establish yourself and get through college is to necessarily deal with this as an added stressor. Now, there's some people that will jump on it immediately and say, I needed that. I was having trouble in school. But for most people, I would say once you are through the transition period out of your parents' house, through college, into a normal working life, as you start realizing, hey, I can't have McDonald's every meal and I probably shouldn't go out every night, when you start to kind of recognize how to look at long-term health, that would be when I would look at trying to evaluate it and institute it as a therapy.
The last thing I wanted to make sure we didn't miss is the genetic component because I'm fairly confident that my father had sleep apnea. It wasn't treated. I certainly do. Andrew does. My sister does.
Yeah,
So I would say that just in our family tree, there's
yeah.
evidence for a genetic component.
Yeah, and again, it's something where I would view it not through the lens of, oh my gosh, I've got to go get genetic testing done to see if I have a particular marker for sleep apnea. It's much more the idea that if your family happens to have an airway that is on the smaller side and manifests as snoring after a couple drinks, or if you're really tired after a long day, then that does raise the likelihood that sleep apnea may be clustered due to the airway size.
Okay.
And that's really the way I would look at it.
Andrew, given the fact that you've joined the club of sleep apnea folks recently, what's your take on all of this now that you're new to it?
I mean, I really am glad that we found out what it is. I'm definitely feeling better after doing CPAP treatment. I'm actually excited to see how it's going to continue because really I've only done it for like maybe like a quarter,
Okay.
so pretty new.
Yeah.
My question is, so I obviously wasn't diagnosed till I was 39. That means there's not maybe not 39 years, but a lot of years of sleep deprivation. How long does it take to do the therapy to recover from
So
all
in
those years of not having?
Yeah, so in terms of the recovery from the sleep deprivation, that doesn't take very long at all. I mean, I'm sure you probably appreciated the first couple of days when you used the CPAP. I know I did. It was an epiphany. It was just an immediate, oh my gosh, I really was much more tired than I thought I was.
Yeah.
I now wake up before my alarm. I've got more energy. It is a marked change. So the sleep deprivation is not something that I'd be terribly concerned about. That's no different than young parents who are sleep deprived with their infant kids and they're breastfeeding and bottle feeding all night long and they think, am I ever going to come out of this brain fog? Yes, they do. It's not permanent. So the sleep deprivation side of it is absolutely reversible. The thing that is a much grayer area that I can't give you clarity on is the idea over the last 5, 10, 15, 20 years where you had untreated sleep apnea, how much impact was that having on your cardiovascular system? And so that's really the issue where, again, if you were smoking cigarettes, if you had an awful diet, if you didn't exercise, if you had family history of apolipoprotein. So there are a lot of other things that play a role as well, but that would be more the question that I would say I don't have a clear answer for you.
Okay.
Kim, what words of wisdom can you give our listeners over and above this? Because I think this was exactly what we wanted, a very comprehensive step-by-step look
Yeah,
at a disease that is clearly not only more common than people imagined, but being recognized by more physicians and more patients as
absolutely. I
something they
mean,
can treat.
when I went through med school, sleep apnea was a throwaway comment, maybe in one lecture, if that.
No, that's more than I got.
Yeah, whereas now it is unequivocally a major, major part of internal medicine, pulmonary medicine, cardiology, family practice, ENT. I mean, it is across multi-specialties. But there's two things that we didn't talk about that I do want to touch on briefly. One is there's a lot of current conversation and rage about the GLP-1 medications for obesity. And a lot of people have seen in the popular media that there's now a drug to treat sleep apnea. And the reality is these medications like Ozempic and Mounjaro and Zepbound, these are medications that absolutely positively can have a positive impact on sleep apnea when they address obesity. So, me as an example, I am a skinny, severe sleep apnea patient. And if I lost a substantial amount of weight on Mounjaro, I'm just going to be a skinnier, severe sleep apnea patient because the physiology of mine never had to do with obesity and crowding in my neck due to excess weight. But for people where obesity or just excess weight is playing a role, if they have moderate or severe sleep apnea, they may be a candidate for those GLP-1s to be covered. And so it's something certainly that they can talk about with their primary care doc or sleep physician.
Yeah, I took the GLP drugs and lost about 23 pounds, and I must admit, I don't think I detected any change in my
Yeah,
sleep
yeah.
apnea at all.
And
Yeah.
again, it doesn't mean they don't have a role otherwise, but the
Right.
idea when they talk about a drug treating a structural problem in the airway, no, it can absolutely help with obesity, but that's as far as I would say those drugs have a role currently. The second thing that I
Yeah.
was going to comment on, so over the years, I can't tell you how many spouses, bed partners have accompanied patients to appointments, and they have sat on the other side of the room with a scared look on their face that they were truly anxious that their loved one was going to die in the middle of the night by stopping breathing. And I always need to tell them to just relax, take a break. This is something where the implication of sleep apnea is over decades, it's not over hours. Our
Well, it is really
brains,
scary. I mean,
yeah,
when you
without a
see it,
doubt.
yeah.
And for people that don't have medical training, it can be devastating. I can tell you, my mother in law, as an example, back when I was in college and I spent time at their house, she would stay up after my father in law went to bed and did chores all night. He then would get up to go teach as a fine arts teacher at the high school, and she would go to bed. And I figured that was their routine. Fast forward years later, the reason she did that was she was petrified she was going to have to call 911 if he didn't start breathing again.
Wow.
Again, that completely altered her adult life because she felt a responsibility to be on guard at night, paying attention to make sure the loved one didn't have a negative effect. And I always tell people, your brain has perfect capacity to wake you up, whether it's been 3 seconds, 30 seconds, 60 seconds, relax. The only times that it becomes potentially dangerous are if people are under anesthesia or heavily sedated on narcotics or drunk to a point they're not initiating breathing by themselves. So certainly there can be the rare dynamic, but for routine sleep apnea, again, it's something where it warrants evaluation, but a shot to the ribs is as much as you need to worry about on a given night.
Andrew, do you have anything else to ask?
No, this is great. Really appreciate it. Dr.
Fantastic.
Connolly, really appreciate it. Thank you. And thank you for helping me.
And me?
It's my pleasure. Hey, we're all in this together. We're all part of the same team.
You did great by all of us, and I certainly send patients to you on a regular basis.
I appreciate it
If I can
greatly.
convince them to go to a doctor,
That's it.
um, mostly because a spouse will say, I think maybe, and I say, yeah, probably.
Absolutely. And it's, again, now thankfully, it's painless enough to have the conversation and, if needed, do the home testing. And if we get to the point of therapy, again, patients' perceptions of the major uncomfortable masks are really overblown. The equipment's gotten better
Yeah,
and better.
let me talk about that as someone who actually was diagnosed in 2008, and now it's 18 years.
Yeah.
The improvements in both the machines themselves and the masks are really significant, plus the fact that there are many choices among the masks. And
Hundreds. Yeah.
what I was told because of Medicare's rules, when you prescribe my next machine, I was more than 5 years, so I was
Yeah.
eligible. They make you go to a class. And one of the things they tell you in the class is that you can change the mask if
Yeah.
need be.
Yeah.
And I did.
Yeah.
The first one they gave me,
Yeah.
a new one that I had never seen before, wasn't very effective. The next one was
Awesome.
um,
Yeah.
tremendous.
No, I
So,
mean, again, the design elements have gotten better and better. And again, when you're dealing with a population at least a fourth of the United States, there's a lot of financial incentive for these companies to get better equipment out there.
and I think we need to reemphasize that this is completely paid for
Yes.
by most
Yep.
insurance plans, including Medicare, which is mine. They
Yeah.
really are quite aware of this and quite attuned to it. So,
Yeah. The only thing that I would say about the insurance coverage, absolutely positively, it is covered. The one thing you have to make sure, though, is that you go through the correct steps. Because when you
absolutely.
do it out of order and you kind of just have somebody order you a machine. It doesn't work that way.
No, that's why I had to go to the
Yeah.
class. That was mandatory for
Yep.
the Medicare program, and
Yeah.
it was fine. I didn't. It was an hour of my time, but it was not that I didn't learn anything. But the
Yeah.
new machines are quite effective. So yeah,
Absolutely. Perfect.
Tim, thanks again.
My
Always a
pleasure.
pleasure. Heal
All right.
up. Take care, man.
Thank you.
Thank you. Great seeing you
Bye.
both.